Morning.
We have an excellent good morning from a little one in the audience. So this session takes all ages. Well, welcome to the 17th annual Judd Symposium. This is the plenary session. This Judd Symposium is our departmental showcase of our early career investigators, originally launched by our former chair from 1977 to 2014, Dr. Louis Judd. During Lou's remarkable tenure, he oversaw the development of UC San Diego's Department of Psychiatry and watched it grow as one of the premier departments in the world. Dr. Judd was passionate about education and aimed to create an environment where clinicians, educators, preclinical and clinical scientists can interact to enhance cross-fertilization. To recognize trainees in support of this goal, he inaugurated this early career research symposium in 2005 to provide a forum for our trainees to showcase their work and to receive feedback. In 2014, the symposium was named in his honor. In just a moment, I'll pass over the Zoom controls to Dr. Pat Judd to tell us more about Lou. Then we'll go to Dr. Jeff Daskalakis to kick off the event. And then finally, we'll hand it over to our Master of Ceremonies for the rest of the event, Dr. Monica Fedorov, last year's keynote speaker. This year, we had about 80 submissions for the Judd Symposium, including many who indicated a willingness to be considered for a talk in this plenary session. These submissions were reviewed by a program committee comprised primarily of trainees. Sean, can you skip ahead to the next slide? This training council did a terrific job behind the scenes to pull this event together, taking feedback from other trainees in their programs in order to make continuous improvements to this session each year. This year, they created a document to guide the speakers, and in the subsequent events that follow, they'll be leading some of the breakout rooms. They've been really a terrific group, and for the first time, this has really been a trainee-led effort. When you see these people around the department, these members of our Council of Trainees, please give them a huge thank you for their efforts for this and for the other things that they do. Before we get started, I want to take a moment to thank Jennifer Hickey Hinojosa for her outstanding continued leadership with educational programs, including this event, and to Sean Ryback for his wizardry with the Zooms and the IT aspects. Today's plenary session features 7 of the top rated abstracts, including this year's keynote speaker, Dr. Corey Weissman. Before I pass over the Zoom to Professor Emeritus Pat Judd, I have one last announcement. Unfortunately, we cannot follow our pre-COVID tradition of an in-person poster session that immediately follows today's talks. The poster session was a terrific opportunity for our department to connect around the science of our early career investigators. Following the recommendations of the Trainee Council, part 2 of this Judd Symposium will be Tuesday, May 17th via Zoom from 9 to 10:30 and will feature several concurrent mini symposia. We've asked the participants to still imagine this upcoming event as an in-person poster session with 5 minutes describing the research and taking another 5 minutes to field questions and discuss their work. For members of the audience, please make the extra effort to carry on the tradition of connecting one another and join us on May 17th for the mini symposia. Let me now pass it over to Dr. Pat Judd to tell us about the person who built and led this great department for the better part of 4 decades, Lou Judd.
Thanks, Greg. Oh, wait, am I? Yeah. Thanks, Greg. It's also wonderful to see some familiar faces. It makes me homesick for the department. So anyway, so Lou started actually, Arnold Mandel was the first chair of the department, and he came down to start the department and invited Lou to join him. And then Lou Arnold stepped aside and Lou became the chair, as Greg said, for many, many, many years. So this was his baby in many respects. And he saw the department as his family. Lou actually grew up in LA, and he went to school at George Washington, and then transferred to UCLA to finish his medical school, and then went into his residency at UCLA. He, as a medical student, he wrote his first paper on obsessive compulsive disorder in an 8-year-old boy. So he had an early interest in research. And his training was interrupted, and he went into the Army. And I think this is a fun fact. He became known as the boxing psychiatrist in Rome, New York. So they had a whole write-up on him. Anyway, then Lou was raised Mormon. And as part of the Mormon life, you go on a mission. So when he was, I think, 19 or 20, he went to London, and he went to Save the Heathens in London. So anyway, there's a picture of him standing on what looked like a soapbox out in the street, sidewalk, preaching to people. And I think that's where his career as a chairman actually began. So anyway, he of course loved research. He and Arnold both were very committed to helping others see psychiatry as a true discipline, and not as some kind of fuzzy wuzzy occupation. So they both pushed to have a better understanding of the neurobiology of mental illness, and to really encourage great researchers here in the department. One of Lou's great gifts was as a recruiter. He was a master recruiter. He wined and dined. One of the faculty told me he even met me at the airport when I was coming here for my interview, which is pretty rare. And he had a great gift for making people feel wanted, making them feel special. So they wanted to join the department. And really, many of the faculty that he recruited have been there their whole careers. Not that many have left to go elsewhere, because he created an environment that made people feel special and really valued. So the high point, one of the high points of Lou's career was being appointed as a director of the National Institute of Mental Health in 1988. He was there for 3 years, and one of his initiatives was the Decade of the Brain. So in this way, he really was able to say, look, mental illness is a result of potentially something challenging in the brain, and we need to investigate the brain. We need to understand how it works. We understand neurobiology. So that then went on. And then, as you know, I think not long ago, there was kind of a new Decade of the Brain, which was initiated. So he loved teaching, he loved research, he loved creating a group of outstanding faculty that could nurture each other. He also was very interdisciplinary. He brought in outstanding psychologists who were incredible researchers, as well as psychiatrists. And he tried to nurture that cross-fertilization among faculty members. So he'd be very proud to be here today, to hear all of you, to listen to what you're doing, and would be so excited about it. One last word. Lou was a Renaissance man. So he not only loved his work, but he was a runner, a tennis player. He loved theater, he loved dance, movies, food. This was a man who we went to some of the best restaurants in the world. And so he lived life fully in all respects. And I think that's something also to keep in mind, that you want to do your research, you want to be good at what you do, but you also want to enjoy life. So anyway, I look forward to hearing you, and congratulations to all of you. Thank you.
Thanks, Pat. Jeff, you're up.
Thank you, Greg. I'm very excited to be part of the tradition that Lou Judd started. Last year's program, I have to say, was my first, and it was truly exceptional. I'm very much looking forward to this year's presentations. The research excellence, as you know, in the department often starts with early career investigators, including those that you'll hear from today and during the mini symposium next month. The department's research excellence can only be maintained when bright and motivated individuals are, of course, guided and supported by equally motivated mentors. And through all phases of one's career, we need those mentors to step up and shine the spotlight on their trainees, as is being done today. The department is tremendously committed towards the development of these future leaders in mental health. And symposiums like these are proof of the fact that UCSD Psychiatry is an incubator for world-class talent. The department is in need now, more than ever, these future leaders. And I have to say that I'm extraordinarily grateful to all of you, trainees and faculty, who stepped up to showcase the exceptional talent in this department. Submissions this year were top-notch, and the caliber of the work that is being presented today is not only comparable, but superior to that of many other departments of psychiatry. So I, of course, look forward to today's talks and the mini symposium in May. I hope you'll all make every effort to join those in May as well. Happy now to kick off the start of today's session and pass the virtual mic over to last year's Judd keynote speaker and fourth-year resident in our department, Monica Fedorov, who will MC today's events. But before I do, I want to personally thank you, Greg, for your wonderful leadership as Vice Chair of Education and Training and for leading this important annual symposium.
Thanks,
Over
Jeff.
to you, Monica.
Thank you so much, Dr. Daskalakis. So now we'll get into what we've all been waiting for. And you can see the agenda that's been presented for today. We'll have 4 15-minute talks followed by a short break, and then subsequently followed by 2 15-minute talks and a final 20-minute talk. After each speaker goes, there will be up to 5 minutes for follow-up questions. And for everyone in the audience, just recommending that you keep your microphones muted throughout each of the talks. In terms of the questions, we will be using the chat function on Zoom to coordinate them for our speakers. You can either post the question in the chat and I will read it out, or you can say you have a question and I'll identify you and you can directly ask the speaker. We'll try our best to stick with the schedule, so it's entirely possible we may not have time for everyone's questions, but we'll do our best. We do encourage you to reach out directly to the speakers after the symposium today if there's additional follow-up questions. And that's really one of the big draws of the symposium itself, being able to kind of initiate that collaboration and connection with others. So without further delay, I would like to introduce our first lead-off speaker. This is Dr. De Guglielmo. He has been working in the field of drug addiction for over 10 years. He has contributed to the development of unique experimental methodologies to investigate the neurobiological basis of drug dependence and identify novel effective pharmacotherapies for alcohol, nicotine, cocaine, and opioid addiction. Recently, he has identified and characterized a neuronal ensemble in the brain that controls alcohol drinking in dependent subjects. He is currently an assistant professor in the Department of Psychiatry at UCSD. His present scientific work is focused on interactions between neurocircuits that modulate pain and addiction. Dr. De Guglielmo has published over 50 research papers in high-quality journals, including Nature Communications, the Proceedings of National Academy of Sciences, Biological Psychiatry, Neuropsychopharmacology, and the Journal of Neuroscience. So without further delay, I would like to hand it over to Dr. De Guglielmo. Thank you.
Thank you so much, Monica, for the kind introduction. I'm gonna share my screen now. Can you see it? Okay. Thank you so much, Monica, for the introduction. It's really an honor to be here for me today. And I'm going to talk about some of the latest results from the lab on the effect of CBD treatment on alcohol dependence. So a lot of attention has been placed on the opioid epidemics in the last few years in US, but if we look at the number, we compare the alcohol number with the opioid numbers, we realize that the alcohol is still a big problem in the United States, with over 88,000 people every year dying for alcohol use disorder. There are currently 3 FDA-approved medications for alcohol use disorder. However, they have limited efficacy, and they are prescribed only to 10% of the patients with alcohol use disorder. So the development of new medication for this disease is still a pressing medical need. And one of the new possible medication could be cannabidiol, derivative of the cannabis plant that is non-psychoactive with anti-inflammatory, antioxidant, and anticonvulsant properties. And the hypothesis is that CBD treatment might counteract the alcohol-induced neurodegeneration, which is thought to be one of the causes of the cognitive and behavioral impairments that are observed in alcohol use disorder. On top of that, the literature shows us that CBD treatment is able to reduce ethanol consumption, motivation, and relapse in animal models of non-dependent alcohol drinking in mice and rats. So we thought interesting to investigate if these effects of CBD in alcohol consumption could translate in animal models of alcohol dependence. So before going to the data, I have to explain you how do we model alcohol use disorder in rats. And of course, we look at ethanol self-administration, but the highest blood alcohol level a rat can reach by self-administered alcohol is around 10 to 90 milligram%. And these levels are not enough to produce the typical somatic and effective withdrawal signs that are observed in alcoholics. It's regular self-administration is relevant to recreational use of alcohol, but has limited relevance to human alcohol use disorder that is characterized by blood alcohol levels on the range of 200 milligram%, compulsive alcohol drinking, and somatic and affective withdrawal signs. So what has been done in the past was to pair alcohol self-administration to a passive vapor exposure, in which animals are trained to self-administer alcohol in operant chambers, and then they are exposed passively to vapor in cycles of 14 hours of vapor exposure, followed by 10 hours of acute abstinence. And by doing this for several cycles, animals reach blood alcohol levels that are relevant for human alcoholism. And importantly, in this model, when they are tested for alcohol drinking during acute abstinence, they develop what we call escalation of drinking. So they drink 2-3 times more compared to their previous baseline pre-vapor exposure in order to self-medicate their negative emotional state of alcohol withdrawal. So this model that is called CIE, chronic intermittent exposure model, it's has been extremely helpful over the year to investigate the neurobiology of the negative emotional state of alcohol dependence. However, still doesn't allow investigation of what drives an individual to move from recreational use to being dependent from alcohol. So the volitional aspects of alcohol dependence are not possible to be investigated with this model. And in order to overcome this problem, a few years ago, we developed a new model that we called ethanol vapor self-administration model, in which animals, in this case, can self-administer alcohol vapor to the point of reaching blood alcohol levels that are in the 200 milligram% range, so significant for human alcoholism. And as we can see at the end of this, in this video, animals are very, very drunk after the session, and when compared to an animal that is non-dependent, they show increased motivation for alcohol, They show somatic signs of acute withdrawal. They also develop the emotional state, the negative emotional state of alcohol withdrawal as measured as increased anxiety and increased hyperalgesia. So going back to the CBD story, what we did was to perform a longitudinal assessment of CBD effects over the course of the addiction cycle, and we used a different animal model based on the stage of addiction we wanted to look at. And so we use ethanol vapor self-administration to study the effect of CBD on the volitional aspects of alcohol dependence. Then we use the chronic intermittent vapor ethanol exposure to study the effect of CBD on the negative emotional state of alcohol withdrawal. And then we use a model of restatement pair in non-dependent, in post-dependent animals to look at the effect of CBD on alcohol seeking and in stress-induced restatement of alcohol seeking. So in the first experiment, we tested the effect of chronic CBD on voluntary ethanol dependence using the ethanol vapor self-administration model. In this experiment was divided in 3 phases. Each phase was characterized by 8 sessions, and the only difference between the 3 phases was the time of the reward duration after a single no spoke. So alcohol was delivered for 2 minutes after each no spoke in the first phase, 5 minutes, and then 10 minutes in the third phase. And CBD was injected since the start of the experiment, and animals were tested in 8-hour sessions every other day. The dose of CBD was 60 milligram per kilogram, injected 30 minutes before the session subcutaneously. We used males and female rats for this experiment. And as we can see from the result, CBD didn't really affect alcohol consumption in this model when the alcohol consumption was low, but in the last phase, when we increased the reward duration and the vehicle control group, as expected, started escalating their drinking, actually it's not drinking, this is alcohol consumption, to the point of reaching blood alcohol levels around 200 milligram%, the CBD-treated group showed significant lower levels of alcohol consumption and blood alcohol levels at the end of the session that were about 120 milligram per deciliter. Also, we recently showed that when you compare an animal that has been made dependent with active vapor self-administration versus animals that are made dependent passively, there is a differential activation in terms of increased FOS expression in brain regions that are that have been associated with the volitional aspects of alcohol dependence, habit formation, and the initial rewarding effects of alcohol, such as the striatum and the nucleus accumbens. But when we compare the levels of activation in the CA, for example, that is an area that has been associated with the negative emotional state of alcohol withdrawal, we see a similar activation in terms of FOS expression. So the next step was to check if the effect of CBD that we observed in the vapor self-administration model might be related to these regions. And being CBD a neuroprotective agent, we looked at neurodegeneration in these regions. And what we found was that CBD reduced, we looked at different markers of neurodegeneration, and CBD reduced cell death and astrocytes in the nucleus accumbens shell and in dorsomedial striatum, while increased mature neurons and oligodendrocytes in the same regions, demonstrating that maybe CBD was able to reduce alcohol intake in the vapor self-administration model by preventing neurodegeneration in the nucleus accumbens shell and in dorsomedial striatum. So in the next experiment, we tested the effect of CBD in animals in which the dependence from alcohol was already established. That is a more translational way to look at these effects. And in this case, animals were, we looked at drinking. Animals were trained to self-administer alcohol in operant chambers, made dependent through vapor exposure, and then tested for their level of drinking during acute withdrawal and treated with CBD or vehicle in this phase. And what we found was that the control animals, as expected, significantly escalated their alcohol intake after vapor exposure, while the CBD-treated animals' alcohol drinking level remain substantially low and not differed from their pre-dependence drinking levels. And importantly, these effects were not related to any CBD metabolism of alcohol effects, since the blood alcohol levels at the end of the exposure were the same between CBD and vapor rats. And also, CBD was able to reduce somatic withdrawal signs and the emergence of the negative emotional state of alcohol withdrawal, as demonstrated by the reduced anxiety in the CBD-treated rats and the reduced withdrawal-induced hyperalgesia in the same group. Finally, we wanted to test the effect of CBD on a model of restatement. And to do this, we used the CI model paired with an extinction restatement procedure. Animals were made dependent, let them drink, escalate their intake, and then placed on an extinction phase in which they were placed in the self-administration chamber. We led them to lever press, but the lever pressing was not associated anymore to alcohol. And finally, the restatement was induced by a pharmacological stressor, yohimbine. And what we found, animals escalated their intake before treatment, so there was no difference between the two groups. And then when we started the treatment during extinction, we found that CBD accelerated the extinction in the CBD-treated animals. And this is also a measure of how much animals are seeking alcohol, since in the first session is the first time they have the lever, but the levers are not associated to the alcohol anymore. And at the end of the extinction, we reinstated the behavior with yohimbine, and what we found was that pharmacological stressor was able to reinstate yohimbine in the control groups, and this effect was completely blocked in the CBD-treated animals. So finally, we started digging a little bit into the mechanism through which CBD might exert these effects in protracted abstinence, and we use a similar paradigm, and animals trained to self-administer alcohol and treated with CBD during protracted abstinence. And we performed some electrophysiological recording in the BLA, the basolateral amygdala brain region that has been associated with craving and relapse of alcohol seeking. And so we recorded from naive alcohol post-dependent rats and alcohol post-dependent rats treated with CBD during protracted abstinence. What we found was that, as we can see here, there is no difference in the three groups in terms of resistant and resting main potential, meaning that we were recording from the same neuronal population. However, when we compare alcohol rats with naive rats, the alcohol rats show reduced neuronal excitability in the basolateral amygdala, and this effect was completely blocked when CBD was in the picture. So when in animals that during the protracted abstinence phase were treated with CBD. So just to summarize what I showed you today, cannabidiol attenuates the volitional aspects of alcohol dependence by preventing alcohol-induced neurodegeneration in the dorsomedial striatum and in the nucleus accumbens shell. Cannabidiol prevents the withdrawal-induced escalation of alcohol drinking in dependent subjects and attenuates the negative emotional state induced by alcohol withdrawal by reducing somatic sign, anxiety, and hyperalgesia. And finally, cannabidiol reduces alcohol seeking and stress-induced restatement, possibly by blocking the alcohol-induced decrease in neuronal excitability in the BLA. And finally, I want to spend my last minute thanking the wonderful group of people that work with me. A particular shout out to Angelica, Caitlin, and Selene, particularly Selene. She has been an honor student in my lab for the last 2 years, and most of this behavioral work is part of her honor thesis. and she has been a tremendous job. And she will have a poster in the Judd Symposium in May 17. So please go talk to her and ask her the more technical question that I couldn't detail today. Also, I want to thank all my colleagues in the Preclinical Addiction Research Consortium, particularly Marcida Kalupi for performing the EFI study, and Paul Schweitzer for his insights in the electrophysiological results. And I want to big thanks to the CMCR that made all this research possible by giving us a grant a couple of years back. And of course, all of you for the attention. Thank you.
Thank you so much, Dr. De Guglielmo. It looks like we have a couple of questions, or at least one starting off in the chat, asking if, do we know if CBD alters the subjective effects of ethanol in humans or animals?
I mean, we don't see any effects. We didn't do, like, for example, a CPP to see if the rewarding effects of alcohol are changed. So that's something that probably should be investigated. But I have no other answer for this.
Okay, and please feel free to, if there's any other questions, to put them in the chat. But I guess I would just be curious as what would be some of the next steps that you're, oh, it looks like we have another question here. So we can do this one first. Any experiments that looked into what receptors CBD may work to create this effect? From Samantha Ayub.
So we are investigating a possible hypothesis. So we started, for example, with the BLA and that particular part of the BLA, because one of the hypotheses is that CBD might act on the CB1 receptor as a negative allosteric modulator, and the BLA, that particular part of the BLA we were recording from is full of CB1 receptors. So this is the first hypothesis we are looking at. But it has been shown CBD acting in 6 or 7 different systems. So it's going to be a long road in front of us before figuring this out.
Okay, great. And I think we might not have time for all of our questions. Dr. Grant, would you like to ask one more question?
You're muted, Igor.
I think you're muted.
There, they always like to mute me. Great paper, Giordano. But I think in response to the first question, the next stages will be to do some research indeed with humans, because you know, your model has shown so importantly that you know, the CBD may affect a very important part of the repeated cycle of addiction and relapse, which is the craving aspect that is so difficult. So although we don't know that it'll work in people, certainly you've set up the basic science to suggest that may be true.
Yeah, and there are several indications in general that CBD might treat withdrawal also of other drugs of abuse, such as nicotine. And
well, and
even the fact that CBD has no side effects, it could be easy to put together, you know, a small study in humans to just evaluate the effects on cravings. Yeah.
Well, those of you who are human addictionologists, remember, put in a grant to CMCR. Maybe we could follow up on Giordano's wonderful work with people.
Thank you.
Thank you both so much. I think in this sake of time, we're going to move on to our next speaker. But again, encourage everyone with additional questions to follow up via email or however is most convenient. So next will be Dr. Monica Lai, and she is a neuropsychology postdoctoral fellow at the VA San Diego, working with doctors Mark Bondi and Lisa Delano Wood. She completed her graduate training at the University of Connecticut and predoctoral internship at the Tampa VA. Her research interests are in using neuroimaging markers to improve their assessment of brain injury and disease, and her current projects lie at the intersection of aging and traumatic brain injury. So Monica, please take it from here. Thank you.
All right, good morning, everyone, and thank you, Dr. Fedorov, for the introduction. I am really excited and honored to be invited today to present my research on the improved biomarker associations using neuropsychological criteria versus the ADNI criteria for the diagnosis of mild cognitive impairment in Vietnam-era veterans with histories of head injury. It is a mouthful of a title. So mild cognitive impairment, or MCI, represents an early or prodromal stage of Alzheimer's disease where cognitive functioning begins to decline, but the individual is largely able to maintain their daily functioning independently. Although not everyone who has MCI progresses to dementia, it has become an important topic for the early detection of Alzheimer's, and it's one of the most heavily researched topics in neurology. Many large studies, such as the Alzheimer's Disease Neuroimaging Initiative, or ADNI, which I'll be referencing a lot, have been investigating biomarkers for the early identification of Alzheimer's disease and evaluating different treatments for it. So of course, we can't have an MCI talk without referencing a Cliff Jack schematic here. So this theoretical framework proposed by Jack in 2013 shows the appearance of different biomarkers over time preceding the diagnosis of dementia. And this includes different cerebrospinal fluid markers like tau and amyloid beta, as well as MRI and PET imaging markers. The exact order and shape of the curves is still in debate and in flux as we have more research and changes in our measurements. The measurements become more sensitive. But generally, these biomarkers can show abnormalities several years before a formal diagnosis of dementia is even made. But as a neuropsychologist in training, one problem we have is that cognitive impairment is all the way over here to the right. And oftentimes that cognitive impairment is determined based on just a single measure or a single screening test, which would have limited sensitivity. So that brings us to the larger issue of how to define mild cognitive impairment. The 2004 working group recommendations by Winblad and Peterson state that to meet criteria for MCI, an individual should be not cognitively normal and not demented, exhibit cognitive decline from both a subjective and objective standpoint, and maintain relatively preserved activities of daily living. So how do we define cognitively normal, and which cognitive tasks should we use to determine objective cognitive impairment? And how important is self-report to the diagnosis? We see many patients who show objective cognitive impairment on our tests, but they and their family might just chalk it up to normal aging. So what do we make of that? Our group, starting with Amy Jack, Mark Bondi, and Lisa Delano Wood, have been studying these questions about MCI for many years. And in 2009, they published a comparison of 5 approaches to defining MCI and found this huge variability in the percentage of adults diagnosed based on which criteria you used. So they proposed this comprehensive neuropsychological criteria, also known as the Jack Bondi actuarial criteria. And our group has published dozens of studies since that's found that the neuropsychological criteria addresses a lot of the sensitivity and specificity issues that come with more traditional MCI diagnostic criteria, such as those used in the ADNI studies. So this neuropsychological criteria was better at detecting both amnestic and non-amnestic phenotypes. It had greater stability over time. It was more significantly associated with Alzheimer's disease biomarkers, and it identified a greater proportion of individuals who would later progress to dementia. More recently, our group, including Emily Edmonds, Katie Bangan, and Kelsey Thomas, examined the problematic false positive and false negative rates in other MCI criteria and where those might come from, such as the inclusion of subjective cognitive complaints, as patients often underestimate or overestimate their own cognitive deficits. Emily Edmonds and colleagues, they conducted a cluster analysis on ADNI participants and consistently found that in participants diagnosed with MCI per the ADNI criteria, about a third of them would appear normal, meaning that they actually performed within normal limits on cognitive tests here. So all of these subgroups for MCI were performing well below normal limits, but there was this cluster-derived normal group, and follow-up studies have found that this group also has normal biomarkers, normal cortical atrophy over time, pretty much parallel to normal aging, which indicates that there's this sizable false positive problem with the ADNI criteria. With my current study, I wanted to build upon that literature documenting the limitations of the traditional or the ADNI criteria and build on the utility of the neuropsychological criteria. I saw this gap in the literature where most research to date has been conducted in relatively healthy samples with few comorbidities. For example, the ADNI study specifically recruits older adults that have relatively little vascular risk and little neurological history. So having worked with veterans for a few years now, I wanted to replicate a lot of this work done, especially by Emily Edmonds, comparing the neuropsychological and the ADNI criteria for MCI, but in this complex veteran population with a history of traumatic brain injury and post-traumatic stress disorder. Knowing full well that TBI and PTSD are these well-documented risk factors for later in life neurodegenerative disease. So specifically, I was looking at cognitive and biomarker profiles cross-sectionally in this sample. So this study was conducted in a sample of 186 Vietnam-era veterans from the DoD ADNI database. So it was a partnership to get this veteran sample. And I restricted my analyses to just veterans that had a history of self-reported traumatic brain injury of any severity. Here's a brief demographic overview of the sample. On average, these veterans were about 70 years old, mostly male, mostly white, and highly educated. And just to note that veterans with diagnoses of dementia were excluded. Most veterans reported a history of about 1 or 2 TBIs, though some reported as many as 7. And there was a wide range of scores on the CAPS, which is a measure of PTSD symptom severity, which is expected given the high comorbidity between TBI and PTSD, especially in veterans. So all participants completed a telephone screening, neuropsychological test battery, and cerebral spinal fluid draw. So here are the neuropsych tests that we used in each criteria. Importantly, the ADNI criteria is limited to just this single memory test. That's just one story memory test. And this coarse cognitive screener, the mini mental, that was essentially used just to exclude dementia. While the neuropsychological criteria includes tests across 3 different cognitive domains. And if it were to be applied in a different battery, it could be used with as few as 2 measures per domain. These are the neuropsychological and ADNI criteria for MCI. Without going through them in too much detail, the major differences was that the neuropsych criteria sought to increase reliability and specificity by looking at more than just one score within a domain. So an individual needed to score below cutoff on 2 or more scores within a domain. But to maintain sensitivity, the cutoff for an impaired score was raised to 1 standard deviation below the mean, as opposed to 1.5 or 2, which has been used by past researchers and clinicians. So the neuropsych criteria was also based solely on these neuropsych tests, these objective measurements, whereas the ADNI criteria requires this subjective memory concern, which we know from past research is contributing to a lot of these false positive and false negative diagnoses. So we applied both the neuropsychological criteria and the ADNI criteria for mild cognitive impairment to our sample of veterans. About 75% of the sample was cognitively normal, meaning that they did not meet either criteria. So this was actually a pretty cognitively healthy sample. About 16% of the sample met neuropsychological criteria for MCI, and about 13% met ADNI criteria. But what's notable here is that the agreement between the criteria was very poor, with the Cohen's cap of about 0.17. And only 4% of them were flagged by both criteria. The neuropsych criteria was likely flagging more veterans because many of them had impaired performances on non-memory aspects like processing speed and executive functioning. We also looked at the effect of ApoE status, since the ApoE gene, particularly the E4 allele, is known to increase the risk of developing Alzheimer's disease. And we found that surprisingly, E4 carrier status did not predict diagnosis by either criteria. Then we looked at the role of PTSD. Interestingly, PTSD symptom severity predicted MCI diagnosis by ADNI criteria, but not by neuropsychological criteria. So we pondered whether this might be because the subjective memory complaint aspect of the ADNI criteria allows the diagnosis to be confounded in part by some severe emotional distress. But research has found that PTSD is a risk factor for Alzheimer's disease and related dementias, so that's something we definitely want to look at further in the future. Then we looked at the associations between each of these criteria and Alzheimer's disease biomarkers, such as tau and amyloid beta. So this graph shows that veterans meeting neuropsychological criteria for MCI, shown in teal, had higher CSF total tau and phosphorylated tau than the cognitively normal veterans, which are shown in red. And that makes sense considering that tau has been highly linked with cognition. And this association holds true after accounting for age and education. In contrast, meeting ADNI criteria for MCI was not associated with any of the biomarkers. So tau and amyloid were similar in those flagged with MCI by ADNI standards versus not. So these results were pretty exciting and in support of the use of the neuropsychological criteria in this veteran sample. But there are some limitations to this sample and directions that we want to take this study in the future. So only a quarter of the veterans actually met criteria for MCI. As I mentioned, it was a pretty cognitively healthy sample. So any subgroup analyses were likely going to be underpowered. And this was likely because the DoD ADNI study was designed to follow cognitively normal veterans over time. So the first phase of their study specifically excluded cognitive impairment based on a telephone screener. So it made it hard for us to find that MCI later. In addition, the DoD ADNI sample was very demographically homogeneous, like many of the past ADNI samples. They were mostly white, male, highly educated, and this is increasingly not representative of our diverse aging veteran population. So some of the ways that I'm starting to expand on this study are by looking at the one-year follow-up neuropsych data to examine diagnostic stability by each criteria, and also looking more into whether PTSD serves as this risk factor for MCI. I also want to dive into the role of subjective cognitive complaints and how they maybe muddy the waters in terms of diagnostic stability. And finally, I plan to investigate these neuroimaging profiles and their associations with different criteria including resting state fMRI, structural measures like cortical thickness, and white matter measures like white matter hyperintensities or DTI metrics. In conclusion, we found that the diagnosis of mild cognitive impairment using neuropsychological criteria is more strongly associated with Alzheimer's disease markers than traditional or ADNI criteria. And in general, MCI diagnostics would really benefit from incorporating more comprehensive neuropsychological methods, particularly for these complex populations that have a lot of medical and psychiatric conditions. So that concludes my presentation, and I want to thank my mentors and collaborators, Drs. Mark Bondi, Lisa Delano Wood, and Emily Edmonds for their help and guidance. Also want to thank the ADNI and the DoD ADNI investigators who were able to make this study possible and by sharing the data. Also thanking the UCSD Department of Psychiatry for putting on this Judd Symposium, and for all of you for your attention. So I'll now open up the floor for any questions or anything I can clarify. I also have my contact information below. If you would like to email me, feel free.
Thank you so much, Monica. Does anyone have, it looks like we have one question from David Moore, if you'd like to say that out loud.
Sure. Excellent talk. Really, really interesting and really well done and very clear. So thank you. So yeah, I was wondering if you were able to do the AD biomarkers in the cognitively normal group, and whether how they look in comparison to either the ADNI or the neuropsychological criteria. Do they look more normal?
Let me pull that up. So you're asking, so the cognitively normal group in ADNI versus neuropsych?
Correct. Yeah.
Okay. So it seems like they were about equivalent. I don't think I did that specific comparison, but it seems like they're about equivalent.
Okay, great. Thank you.
Mm-hmm.
We'll do one more question and then move on to our next speaker. Christine Smith, if you want to read off your question. Otherwise, I'm happy to do so.
Sure. So on a recent NIA grant review, we're trying to identify more sensitive cognitive tests. I was told that cognitive tests are not needed anymore because we now have biomarkers to detect risk for Alzheimer's. Any thoughts on this idea given your findings?
Yeah, I mean, I don't want to be out of a job as a neuropsychologist researcher, but I like our group has found that cognitive impairment or neuropsych testing can actually predict some of the biomarkers. So the abnormalities, very subtle abnormalities in cognitive testing, can show up before these biomarkers. So I think that's a strong argument that we still need to have this cognitive impairment. Not to mention, cognitive impairment is much more related to like daily functioning, like what the patient is going to come in for and complain to doctors about, or their family will complain to doctors about. So I think there's still a lot of great room for cognitive testing. And we're just going to keep coming up with more and more sensitive measures that will give biomarkers a run for their money. But of course, they would both be used in complement with each other in future research.
Good answer. Thank you.
Thank you so much. I see Dr. Kremen has one question, and then we'll have to wrap things up. I think you're muted, Dr. Kremen.
Not a question, but I just wanted to add to that prior question that Christine raised, which is that it's well known that on autopsy, a large proportion of adults are positive for Alzheimer's biomarkers and have no history of dementia. So that relying simply on those and not cognition just doesn't make any sense.
Good point. Thanks for adding that.
Great, thank you, everyone. We'll move on to our next speaker, and this is going to be Mckenna Williams. She is a third-year doctoral student in the SDSU-UCSD Joint Doctoral Program in Clinical Psychology, where she's specializing in neuropsychology. Her mentor is Dr. William Kremen at the UCSD Center for Behavior Genetics of Aging. She graduated from UCSD with a bachelor's degree in cognitive science and from SDSU with a master's degree in psychology. Mckenna's research focuses on characterizing early changes associated with Alzheimer's disease by investigating neuroimaging biomarkers beginning in midlife. She will be presenting work today from the Vietnam-era twin study of aging. Welcome, Mckenna.
Thank you so much. I really appreciate the introduction and the opportunity to speak with you all today. So let me get my screen arranged here. So I will be presenting work from the Vietnam era twin study of aging, and I will jump right in. So the work that I will present today focuses on this one overarching question: how might neuroimaging signatures improve characterization of very early risk for Alzheimer's disease? So we'll walk through 3 sets of findings to address this question. First, beginning with the utility of these signatures in midlife prediction of incident mild cognitive impairment. Second, how these signatures may change across midlife and into early old age from a twin modeling perspective, as well as some preliminary work looking at relationships between signatures and Alzheimer-related plasma biomarkers. So starting with some background on Alzheimer's disease signatures, we know that some degree of cortical thinning is associated with typical aging. And we also know that some brain regions are particularly vulnerable to Alzheimer's disease pathology. So Alzheimer's disease signatures are composite scores of brain morphometry, and they typically include metrics like cortical thickness, and they represent a way to capitalize on these regional patterns of neurodegeneration. So these signatures have been shown to be useful tools for distinguishing between Alzheimer-related neurodegeneration and age-associated brain changes. Almost all prior research has been limited to signatures that rely on macrostructural neuroimaging metrics like cortical thickness, but a signature based on diffusion MRI metrics could perhaps pick up on earlier microstructural changes associated with Alzheimer's disease. So gray matter mean diffusivity is one diffusion MRI metric where increased values are thought to reflect microstructural degeneration of cellular membranes or inflammation. And our group has previously shown that variation in gray matter mean diffusivity is both heritable and partly influenced by genetic factors that are distinct from those influencing cortical thickness in work led by Jeremy Ellman and Nathan Gillespie. So there's something unique that gray matter mean diffusivity captures, and increased cortical mean diffusivity has been found in individuals with mild cognitive impairment as well as Alzheimer's disease, supporting the idea that measures of cortical mean diffusivity may be able to pick up on these very early Alzheimer-related changes. And the majority of studies on these signatures has involved adults over the age of 70, which is missing a critical window of time during midlife in which Alzheimer-related changes may begin to emerge. So we sought to examine the utility of these signatures during midlife using the VETSA sample, which allows us to essentially shift that focus in age back by about 20 years. So in the baseline wave of the VETSA sample, participants were between 51 and 60 years of age. The VETSA is a longitudinal study of cognitive and brain aging that's currently on its 4th wave. And it comprises a community dwelling sample of male twins that's largely white and non-Hispanic. And the sample is unique in that it is a genetically informative twin study with longitudinal MRI data, and participants are very similar to American men with respect to health, lifestyle, and education characteristics. So in the VETSA sample, we investigated the predictive utility of two Alzheimer's disease signatures. One previously validated signature based on cortical thickness and hippocampal volume. And this cortical thickness signature was previously developed and validated in a separate sample in work led by Linda McAvoy. And we applied these same regions and same weights to measures of cortical mean diffusivity to create a novel gray matter mean diffusivity signature. And we found that this novel signature based on cortical mean diffusivity significantly improved predictions of progression to mild cognitive impairment 12 years later, beyond age and polygenic risk for Alzheimer's disease, whereas the cortical thickness and hippocampal volume signature did not improve prediction. So this study was the first to use a gray matter mean diffusivity signature, and our results support the idea that changes in cortical mean diffusivity may emerge before changes in cortical thickness. And our results also demonstrate that a gray matter mean diffusivity signature may serve as a useful imaging biomarker as early as middle age. So in the same study, we found that participants who were cognitively normal at baseline and then later progressed to develop mild cognitive impairment initially showed higher cortical thickness at earlier ages, but lower cortical thickness signatures at later ages, indicated by that red line on the left. And this was an unexpected finding, given that higher cortical thickness is typically thought of as a protective factor. But that unexpected finding is in line with a theoretical model of very early changes in cortical thickness and mean diffusivity along the Alzheimer's disease continuum. So the figure on the right is a model proposed by Montal and colleagues, and it's based on prior evidence from cross-sectional studies, which suggests an inverted U pattern in which cortical thickness initially increases in very early disease states. This could possibly reflect neuroinflammation in response to disease pathology, and then subsequently decreases with disease progression and onset of symptoms. So that theoretical process is displayed with the red line, and it shows mirrored changes in mean diffusivity. So if these biphasic changes occur very early in Alzheimer's disease, this presents a bit of a dilemma in that higher cortical thickness could mean two very different things for different groups of people. And understanding that difference between higher cortical thickness indicating a risk versus a protective factor carries important implications for the use of these neuroimaging measures as markers of disease progression. So despite cross-sectional evidence from prior studies, the longitudinal relationships between cortical thickness and mean diffusivity had not been explored. So given that VETSA is a twin study, we next leveraged our twin data in biometrical modeling to examine genetic underpinnings of each signature, as well as the longitudinal relationships between structural and diffusion-based signatures across a 12-year period. So we know from prior work by our group that cortical mean diffusivity and cortical thickness each capture some unique information, but genetic and environmental influences on the pattern of changes that each signature captures, and also how the relationship between these signatures may change across time, was unknown. And also, given that Alzheimer's disease and age-associated neurodegeneration share a considerable degree of regional overlap, it's possible that these signatures may function to a large extent as indices of general brain aging. So in addition to whether each signature captures unique variants to the other, we also examined the amount of shared variance between the signatures and a validated MRI-derived measure of brain age. In results from the twin modeling, here we can see genetic and phenotypic correlations displayed among our three measures just at wave 1. And before jumping into these results, we found that each of the three measures was highly heritable, with heritability estimates for the two signatures ranging from 0.56 to 0.72 across the three VETSA waves. So this means that about 2/3 of the variance in each of these signatures can be attributable to genetic variation in the population. And so now pictured here, zooming in on just wave 1, we see that the 2 signatures and brain age were all correlated, but each measure captured unique phenotypic and genetic variants. So for example, starting with this relationship on the left between the 2 signatures, we see that they share a genetic correlation of -0.37, representing the degree of shared genetic variance between those 2 measures. And confidence intervals for these correlations did not include or approach 1, indicating that most of the variance in each signature at wave 1 is unique and not redundant with the other. We also see that each signature captures some unique information that's not explained by general brain aging. So now looking at just the phenotypic correlations between our 2 signatures, as we saw on the last slide, here at wave 1, the phenotypic correlation between the signatures was relatively low at -0.28. And this correlation increased in magnitude at waves 2 and 3, but at every wave, the signatures are each capturing unique phenotypic information. And we see a very similar pattern in terms of genetic correlations. When we examined cross-temporal correlations between the signatures, we found that baseline mean diffusivity signatures showed robust associations with cortical thickness at waves 2 and 3, with estimates around -0.5. Whereas cortical thickness signatures at wave 1 show small and diminishing relationships with subsequent mean diffusivity signatures. So to our knowledge, this is the first study to look at these measures longitudinally, and our results support the idea that Alzheimer-related changes in mean diffusivity may emerge before changes in cortical thickness, again, really underscoring the utility of mean diffusivity signatures as very early Alzheimer-related neuroimaging biomarkers. So evidence seems to be building that the cortical thickness and mean diffusivity signatures each capture unique and meaningful information despite being based on the same brain regions. So to break this apart a bit more, we next looked at individual regions within each signature and their associations with cross-modal signatures at wave 3. So on the left here, for regions in the cortical thickness signature at wave 1, we see the strongest association between hippocampal volume at wave 1 and later wave 3 mean diffusivity signatures, which you might expect given early involvement of the hippocampus in Alzheimer's disease. Whereas in contrast, for regions in the mean diffusivity signature at wave 1, almost all regions show relatively moderate associations with later cortical thickness and volume signatures. But notice here that the hippocampal mean diffusivity at wave 1 shows the smallest association with later cortical thickness signatures. So this pattern that we're seeing and these differences emphasize our findings that the signatures each capture unique information, which may represent different stages or processes of disease pathology. And in the future, we plan on developing a mean diffusivity signature with its own regions and its own weights that may be better suited to pick up on these subtle changes and yield even stronger prediction. So far, we've seen that the relationship between mean diffusivity and cortical thickness signatures is quite dynamic across midlife and into early old age, which may complicate interpretation at a single time point. So looking ahead to better characterize an individual's trajectory of disease risk, we aim to examine the relationship between these signatures and Alzheimer-related biomarkers such as amyloid beta, tau, and neurofilament light, with the idea that these biomarkers, together with the signatures, could provide really important information related to staging across this continuum. In our preliminary analyses displayed here from mixed models in the VETSA sample, we examined the relationship between total tau and mean diffusivity signatures. And we look at this relationship as a function of the level of cortical thickness and hippocampal volume signatures. Again, with the idea that using the signatures together with Alzheimer-related biomarkers may provide meaningful information related to disease stage. So we see here that the relationship between tau and mean diffusivity signatures depends on the level of cortical thickness. And this differential relationship exists among a cognitively normal group but not among a group who have progressed to develop mild cognitive impairment. So in the cognitively normal group on the left here, we only see a significant positive relationship between tau and mean diffusivity among individuals with higher than average cortical thickness, which may be in line with the biphasic model of changes and suggests that higher cortical thickness may carry different meanings in different contexts. So concluding with referring back to our overarching question of how might neuroimaging signatures improve characterization of very early Alzheimer-related changes, we've shown that a mean diffusivity signature at average age 56 among cognitively normal men improves prediction of 12-year progression to mild cognitive impairment. We've also demonstrated that each signature is highly heritable and captures unique variants, even among the same brain regions, and that variance is not redundant with a measure of brain age. Our results are also in line with changes in the mean diffusivity signature predating changes in the cortical thickness signature. And finally, in our preliminary analyses, we've shown that the relationship between tau and mean diffusivity signatures appears to depend on level of cortical thickness signatures and differs across cognitively normal and mild cognitive impairment groups, which may be in line with a biphasic model of changes across the Alzheimer's disease continuum, and suggests that using the signatures together may improve and provide important information related to disease stage. So collectively, these findings establish the value of studying both structural and diffusion-based signatures as early markers of Alzheimer's disease risk beginning in middle age. And they specifically emphasize the utility of a mean diffusivity signature as a very early neuroimaging biomarker for Alzheimer-related changes. And before I end with taking questions, if there are any, I'd like to thank the many people I am very fortunate to work with and to learn from. Especially would like to thank Bill Kremen for his excellent mentorship, as well as the entire Betsa team led by Bill Kremen and Carol Franz. I really appreciate the opportunity to speak with you all today and would be happy to take any questions.
Great, thank you so much, Mckenna. Opening it up to questions that anyone has for the next couple of minutes. Please feel free to raise your hand or put it in the chat, whatever you prefer.
May I ask a question, Monica? It's Michael McCarthy.
Yes, absolutely.
I started to type it, but it was easier to just speak in. McKenna, great talk. I'm curious about looking at mean diffusivity across cortical and subcortical structures. In the cortex, you have very long white matter projections that go across the corpus callosum or to the thalamus, whereas in a place like the hippocampus, the neurons are just shorter and they don't project quite as far. And I'm curious if you have to consider the neuroanatomy here when you're comparing mean diffusivity across cortical and subcortical structures.
I think that's a great point. And I would agree that, yes, I think you do have to consider those differences, and that it seems like, this pattern that we're seeing, cortical thickness and mean diffusivity are capturing different things. So whether that's related to the neuroanatomy or separate processes or disease stages, I don't know if we know that yet, but definitely important to consider that. And also, I didn't get into it in this talk, but important to consider possible influences of partial voluming effects. And so that's something we talk a lot about in our group and work to address.
Thank you so much, McKenna. And looks like there's a lot of good comments congratulating you in the chat. So awesome job. I think for this, just to kind of keep to our schedule, if there's nothing else, we'll move on to our next speaker. And that's going to be Dr. Judith Lobo. And we'll continue with the theme until the break of some more neurodegeneration type of disorders. So Dr. Judith Lobo is a postdoctoral fellow with the HIV Neurobehavioral Research Program under the guidance of Dr. David Moore and Aaron Sutterman. She graduated with a PhD in cognitive neuroscience from the University of Miami, where she began working with aging populations and postmenopausal women living with HIV. At her current postdoctoral position, she continues to work in the studies that involve older adults, including studies on successful aging and aging with HIV. So please welcome Dr. Judith Lobo.
Good morning. I'm very honored to talk to you, especially with such a great selection of papers. I'm going to talk to you about something that is a project that I'm very excited to share. CSF markers of Alzheimer-related pathology relate specifically to memory impairment in older people with HIV. I have a lot of great people on my team, and most of us who work with HIV and aging, and for a good reason. The proportion of people with HIV who are age 50 years older is growing. Between 2000 and 2016, the amount of people who were HIV positive in the world doubled from 8% to 16%. In the US, over half of the people who are HIV positive are over 50. And in 2030, we expect that to be closer to 75%. With this aging population of people who are HIV positive is probably due to an improvement in antiretroviral therapy over the years. With better therapy, there's increased longevity in people who are HIV positive. They're able to live longer and fuller lives. But we still see some cognitive impairment related to HIV. In the DSM, this is known as HIV-associated neurocognitive disorders. And our group has found that it persists in about 45% of people with HIV. And so as people are growing older, they're also increasingly at risk for Alzheimer's disease, and something that the rest of the speakers have defined really well, mild cognitive impairment. So as you've heard, mild cognitive impairment is a precursor for Alzheimer's, but they do not necessarily meet criteria for dementia. They are able to live independently. And among people with HIV, their increasing age puts them at 4.8 higher odds of memory deficit and entering into this MCI state. When you have HIV, especially chronically, you have all these biological mechanisms that are thought to cause other issues, other comorbidities, including chronic inflammation. There's higher rates of hyperlipidemia, and the viral proteins themselves can cause damage. Inflammation in general is also a condition that is thought to be a risk for MCI and Alzheimer's pathology. There's also a concern that people who are HIV positive can also have age-related conditions that appear sooner, kind of leading to a premature aging state because they're occurring 5 to 10 years earlier among people with HIV. This is, it's kind of tricky, however, to tease apart how much of the cognitive deficit is due to HIV and how much of the cognitive deficit could be due to MCI because of the overlap of cognitive abilities that are impacted. In HIV, you have this wide range of cognitive abilities that you kind of see change, including episodic memory, which is typically measured when you're trying to diagnose HAND. But episodic memory is also a key feature of MCI. And so when you have that overlap, how can you tell that someone who is aging with HIV is at risk for converting to Alzheimer's? As we have heard earlier, we do have some tools at our disposal. Markers of Alzheimer's include amyloid beta and p-tau. Amyloid beta 42 are plaque deposits, and neurofibrillary tangles of phosphorylated tau proteins are pathological characteristics of Alzheimer's. They typically develop about 5 to 10 years earlier than cognitive deficits, so they kind of allow us to have a little bit of time before you start to see cognitive deficits. In the Alzheimer's literature, typically amyloid beta is lower than in people who are cognitively normal in the CSF. P-tau is higher, and there's also a ratio that has emerged where you can measure p-tau over amyloid beta, and this ratio, along with the individual markers, are better predictors of cognitive deficits. So knowing that we have these CSF biomarkers to detect MCI, this might be a starting point to be able to distinguish HAND from MCI. Among people with HIV, the p-tau and amyloid beta research is a little bit less consistent than Alzheimer's, particularly p-tau. P-tau is sometimes similar, higher, or slightly lower than the control group. In our group, they have found that amyloid beta plaques in actual tissue samples are present in HIV brains post-mortem, and the levels are actually lower in people with HIV than those with Alzheimer's. So right now we have some information, but we still do not know the utility of these CSF Alzheimer's biomarkers to be able to tease apart MCI from HAND among people who are aging with HIV. And so our research question for this study was, can we use these CSF markers of Alzheimer's pathology to identify older people with HIV who are already kind of on that trajectory to cognitive deficit due to Alzheimer's? And we wanted to see if these CSF biomarkers, amyloid beta, p-tau, and the ratio relate to memory performance versus the other cognitive domains that are more associated with HIV specifically. So processing speed and complex visual motor coordination is something you would typically see in HAND, but not necessarily in Alzheimer's. So perhaps that can help us tease this apart. Ultimately, in a broader sense, we hope to contribute to a body of research that will allow to not only help distinguish people who have HIV who are kind of going to this Alzheimer's trajectory, but also kind of intervene early so that we can allow more appropriate life planning and have better success in terms of therapeutic interventions so that we can kind of predate these changes. Our participants came from something called the National NeuroAIDS Tissue Consortium. It was established in 1998 by the NIMH and the NINDS. And basically they follow people who are HIV positive and negative, and they are pretty well characterized in terms of neurocognitive assessment. And then post-mortem, their tissues are stored and distributed, including CSF, which is what we requested for this study. It's a multi-site project. Out of the 4 sites, one of them is here at UCSD. From this larger sample, we had 31 people with HIV. Overall, broadly, our sample was about 56.3 mean age. They were 58% white, and they were 84% male. Our participants were HIV positive. 90% of them were on ART, 45% of them had a HAND diagnosis. Their nadir CD4 count was underneath levels where you would consider them to be in AIDS. So most of our sample was on Alzheimer's medication, and they had their disease characteristics being tracked. So given that their HIV status is more or less stable, what can we do in terms of their Alzheimer's pathology? The CSF levels of p-tau and amyloid beta were measured using commercial suspension array immunoassay. The neurocognitive domains that we chose were those that would help us study learning and memory, speed of information processing, and complex visual motor coordination. For learning and memory, we use the Hopkins Verbal Learning Test, the learning and the delayed recall score. And we also use a visual measure, the brief visual spatial memory test, the learning and the delayed recall score. For speed of information processing, we use the Waze 3-digit symbol task, and for the complex visual motor coordination, we looked at the group pegboard test. We use linear regressions to look at these relationships between the cognitive test scores and our CSF markers, and we adjusted for demographics and comorbidities. We had like a long list of covariates that we could have take into consideration. So what we did is we ran the models and only retained the covariates if there was at least a trend in terms of their contribution to the association. The ones that actually survived were age, and we had a few more for the delayed recall score of the HVLT. So what did we discover? Well, we found, first of all, that the ratio was the one that had the most significance in terms of those linear regressions. As you can see in chart B, the BVMT learning score, worse performance was associated with a lower log ratio level in diagram C, you will see that the delayed recall score, worse performance, was associated with a smaller ratio score of p-tau or amyloid beta. And finally, HVT delayed recall score was also associated with worse performance, was associated with a lower ratio level. So we did see some trends in terms of the memory scores, but none of the other cognitive domains, including those that were more affected in hand. We did find one other thing, that amyloid beta alone outside of our ratio was associated with BVMT learning score. This one's a little bit more confusing because lower levels of log CSF amyloid beta are more indicative of Alzheimer's pathology. And in our case, lower levels of amyloid beta were associated with worse performance on the BVMT learning score. But that's all that we really found. The p-tau levels didn't actually associate with any of the domains when you looked at it by itself. And none of the CSF markers of Alzheimer's pathology were actually associated to our more hand-specific cognitive domains, including information processing and complex visual motor coordination. So overall, we found that our ratio of p-tau over amyloid beta, which are indicative of greater pathology among people who have Alzheimer's, was related to poorer learning and memory. So at least we found something that was consistent. It was more associated with Alzheimer's. Amyloid beta alone, lower levels were associated with poorer learning, which is also consistent with the literature. And among people who have Alzheimer's, and lower amyloid betas are associated with more cognitive deficits. None of the other biomarkers were related to the more hand-related cognitive domains, which adds to the specificity of these CSF markers to allow us to see memory-related deficits. And the phospho-tau levels alone did not really relate to any of the cognitive domains. We still have work to do. Our sample, as I mentioned, was largely male. So further studies would be needed to determine how this relationship looks in women. Our study was also cross-sectional. Longitudinal studies are underway, but also necessary to determine if CSF markers of pathology are an early indicator of Alzheimer's among people with HIV. And I'm also hoping to kind of spread this research to blood-based biomarkers so that we can use less invasive medical procedures to kind of have this early detection of Alzheimer's, and for also people who are more limited in terms of what kind of tests they can receive. I am no island. There were a lot of great people that helped me with this project. I'm very lucky to be mentored by Aaron Sunderman on this project and David Moore. I am a T32 postdoctoral fellow under the TRAIN program, so I'm grateful for that grant. There's also many other grants that help make this project possible, including the HNRP core grant, the CNTN grant, and the California National NeuroAIDS Consortium project in general. I'm happy to take questions. Please feel free to drop questions through the chat too.
Great job. Thank you so much, Judy. So we do have a minute or two for questions if anyone wants to. Oh, it looks like Dr. Grant is raising their hand. Go ahead. Oh, I think you're muted.
Yeah, I was going to say a really great talk. Thank you. Did you look, and maybe I missed this, also at CSF inflammatory markers as well as the markers of neurodegeneration?
Not in this study. It's actually something that we're working on right now to see how inflammatory markers in CSF and in plasma relate to these sort of associations, including the cognitive domains.
Because it's possible, given that HIV is associated more with neuroinflammation and Alzheimer's less so, although of course there is inflammation in the brain, but the markers may help separate. Yeah, thank you.
Yeah, absolutely.
Great. If there's no additional questions at the moment, we'll take just a short 5-minute break and then go into our next couple of talks, moving more into anxiety, depression, and suicidality. So thank you so much, everyone. So far, you've all done an amazing job, and we'll just break for a couple of minutes now. All right, everyone, we're gonna start back into our next set of talks here. So I would like to introduce Pauline Goker. She is a graduate student at SDSU and UCSD Joint Doctoral Program in Clinical Psychology, working with Dr. V. Robin Weersing on youth internalizing interventions. She is currently doing a pre-doctoral internship at the University of California, San Diego and the VA in San Diego in the all-child track. And she's working with youth with moderate to severe psychopathology on both an outpatient and inpatient basis. So please welcome Pauline Goker.
Thank you so much. I'm very excited to be here and share some of my work with you. So today I will be talking about the early indicators of response in pediatric anxiety and depression treatment. So let me jump right in. So just like in adults, anxiety, depression in youth is very prevalent, impairing, and comorbid. It is one of the it's actually the leading mental health problems in youth. And luckily, we do have evidence-based intervention. So we do have some psychosocial monotherapies and also transdiagnostic treatments that are available. And we also do know that adding medications can be very effective. But across all of these treatments, the response rate is only about 50 to 60%, which means that about 40 to 50% of youth do not adequately respond to treatment. And so this response rate is something that we really want to boost. So one way to be able to potentially do that is to identify likely non-responders early in treatment so that we can intervene and either add something to the treatment, change the treatment strategy to kind of boost them from this likely non-responders to likely responders. And so in the evidence base right now, there are some promising tailoring variables. And so those are factors that we can basically use to trigger a change in treatment and therefore a change in response. And those are both symptomatic and treatment process predictors. So treatment process predictors would be things like therapeutic alliance, child engagement, things like that. But there's still a lot that we need to know about these. So for example, which of these variables matter the most and how can we best utilize some of these measures that we have available? So for example, should we be using a youth versus parent report? Is this improvement score better than, for example, looking at how somebody is doing at any given moment? And then once we do know some of these answers, can we build a combined predictive model to be able to pretty accurately identify early who will likely be a responder at the end of treatment and who will likely not be? And so this is basically what we set out to do in our study. So we used the Brief Behavioral Therapy, the BBT project by Dr. Weersing, who's my mentor at SDSU in the JDP in clinical psychology. And this was a randomized controlled trials where we were testing the effectiveness of behavioral interventions delivered in a pediatric primary care. So these youth were between the ages of 8 to 16, that on average, they were about 11 years old and about 21% were Latinx. And they were randomized to one of two groups. So one of the groups was the BBT group, where youth received 12 sessions over 16 weeks of graded engagement, basically. So we taught them about exposures and conducted exposures and also behavioral activation. And then they were also taught some skills like problem solving and relaxation skills to basically support this graded engagement process. So it was about 95 kids in that group. The other group was referred to or randomized into the assisted referral to care, which is basically what it sounds like. We supported them to, so that they can connect with services in the community, but they did not receive the BBT protocol. And so very much in line with the response rates I just described, 57% of BBT youth were considered responders at the end of treatment. 43% were considered non-responders. And so some of the measures that we used for the study, week 0 right here is the baseline where we collected demographic information, diagnostics, and then also self-reports. So the SCARED is an anxiety self-report and parent report, and the MFQ for depression. Week 8 is about the midpoint in treatment right here. So we got those self-report symptomatic questionnaires again. And week 16 was post-treatment. So again, we got diagnostic information, treatment outcomes, and the self-reports here again. Treatment outcome was evaluated with the CGI, where a 1, very much improved, or 2, much improved, was considered a treatment response. So those youth would be considered treatment responders, but a 3 to 7 was not considered a response. all throughout, we also got this treatment process measure. So basically we were able to get child engagement, parent engagement, homework completion, and therapeutic alliance. And those are collected at each and every session. I will be focusing on sessions 1 through 8 in my talk today. So in the results, one of the things, so I'll talk about the symptomatic predictors first. And what we basically wanted to figure out is which one of these is going to be most predictive of treatment response or non-response. And so we specifically looked at this midpoint score in these self-reports, also at the change score. So how much did they improve from baseline to midpoint? And then we also tried to see, can we develop a cut point on these measures that would make it even easier? We don't have to look at a continuous score, but can have this cut point to decide if some, to basically help us determine whether or not somebody will likely be a responder. And so these are the results for the midpoint score. So as you can see, all of them were significantly predictive, but this child-reported anxiety and parent-reported depression did better than the others. And so that was kind of one of the things that we're wondering about. Do we really need both, right? Is one better for one set of symptoms than another? And so it started emerging that child-reported anxiety might do a little bit better than parent, and parent-reported depression a little bit better than child. Looking at this change score, so basically the percentage improvement from baseline to midpoint, only the child-reported anxiety improvement was predictive, the others were not. And when comparing this though to the midpoint score right here, the improvement did not perform quite as well. So I'll talk about that a little bit later. In terms of developing this cut point, so we wanted to keep our sensitivity and specificity above 0.7 in order to be considered a good cut point. And so only this child-reported anxiety score met those criteria. And as you can see, the cut point here is at 25, which is actually also this clinical indication. If somebody is above 25, we think that they're likely to have an anxiety disorder. If they're below, they likely are not. And so it turned out that at this midpoint in treatment, 25 is also the score that can help us decide or predict who might be a responder. None of the others met criteria. And similarly for the depression one, the MFQ right here, it didn't quite meet criteria, but 10 was the best. The parent-reported MFQ score of 10 was the best out of the bunch. But when comparing them again to these continuous scores, this scared cut point performed very well. The 25 performed better than this continuous score right here, but the parent-reported depression continuous score actually performed better than this cut point. And again, I'll talk about a little bit later about why that might be. So the process predictors, again, what we were looking at was child engagement, therapeutic alliance, homework completion, and parent engagement. And for these ones, again, looking at the midpoint score, then also looking at the average, because we did have it for every single session. So at the average of sessions 1 through 8, and all of those were significant predictors, except the therapeutic alliance right here. But what I really wanted to know is the session by session. So basically, can we identify a single session that we can use and incorporate into an overall model that would basically cut down on some of the burden that we would otherwise have in clinical care of trying to collect all of that data? So is there a session that we can identify that would be on its own, basically in the combined model, highly predictive? And so the first step here was to look at the correlations between the treatment process variables. And so what we were seeing is that child engagement and therapeutic alliance were very, very highly correlated with one another, as were homework completion and parent engagement right here. So highly, in fact, that putting them into the same model could lead to issues of multicollinearity. And so we decided to just go with 2, basically carry 2 forward. And that turned out to be child engagement and parent engagement, just because individually those performed better than the other 2. So for child engagement right here, you can see that the youth that are going to be responders perform much better throughout. So from the very beginning, they do better than the non-responders right here. So both of the groups do see a little bit of an improvement, but it stays pretty consistent. And so for this one, session 2 was the earliest meaningful session that we then wanted to include in the combined model. For parent engagement, we saw this pattern. So in the beginning, parent engagement did not really differentiate between the groups. But then as we get into these later sessions, which is when we started going from psychoeducation, problem solving, relaxation skills, and things like that, into actual active practice, so doing exposures and behavioral activation, the responder group, their parent engagement went up quite a bit, while the non-responders actually had a little bit of this downward slope, where session 8 differentiated really, really well between the two groups. And so in building this overall exploratory model, those were the variables that we included. So basically this cut point score here for child anxiety, parent reported depression continuous score, session 2 of child engagement, and session 8 of parent engagement. And again, this it was really valuable to know that yes, multiple reporters can give us good information, but we also are able to minimize some of the clinician and family burden by not having to collect quite as much data as we would if we included average scores, for example. And so as you can see, all of these were highly predictive uniquely. So in the model, parent engagement was right outside of that. But overall, altogether, we were able to correctly classify 76.5% of non-responders and 91.3% of responders with the help of this model, which is quite promising. So what do some of those things mean? So again, session 2 child engagement. In this session, the youth were asked to do relaxation exercises, which are not, they're not that demanding. They shouldn't be that difficult. And so if a youth is less engaged in this session, it could have a whole number of reasons, but some of them could be that they're having trouble with focus, for example. And one of the interventions that we could do at that point is to assess that and see if there's something that we can do to help them with this. It might also be that the youth is nervous, so they might benefit from extended rapport building, psychoeducation. It might be that they're not quite ready for treatment and so might benefit from some motivational interviewing, for example. One of the differences between adults engaging in treatment and kiddos engaging in treatment is that usually adults kind of bring themselves in and want to engage. And when it comes to youth, usually it's their parents that are driving that and are signing them up. And so it could be that they're just not quite ready at that time. These midpoint clinical symptoms are also important to consider. Again, this was this active practice that they were doing at that time. And we did think that it was very interesting that where the youth are in terms of their symptoms at that moment of midpoint, it seems to be more important than the improvement, which again, in clinical terms is really important to remember, because a lot of the time when our clients do show some clinical improvement, we get excited and we think that, that's like we're on the right track. And we very well might be, but it might not be quite enough to stay the course just to see that improvement. We might also have to see at this midpoint, are they actually below a certain point in their symptoms? And then also good to know that, youth and parent report does provide meaningful information. And so it's important to try to get both. And then this session 8 parent engagement, again, it was just outside of significance, but it did provide a meaningful contribution to the model overall. And so in this one, it kind of makes sense because when the youth are engaging in exposures, when they're engaging in behavioral activation, they might really benefit from parental facilitation of those things. So they might need somebody to encourage them, for example. They might need somebody to drive them to the mall to conduct an exposure. They might need their parents to allow them to go to that sleepover and things like that. And so again, these are opportunities for intervention. So parents might benefit from psychoeducation and encouragement to truly appreciate their role in the youth treatment and how they can be helpful. They might also benefit from tangible help. Some of these parents might have multiple jobs, they might have multiple children that they need to take care of. And so if they got help with certain things, it might make it more likely for them to then in turn be able to help the youth engage in treatment. So there were some limitations to this study. The sample size was not small, but it was small enough to be limiting in some ways. So we weren't able to really look at too many, include more sessions, for example, look at too many moderators or anything like that. We definitely do also need a more diverse sample. So in terms of ethnicity, socioeconomic status, especially, for example, it is quite possible that some of these other predictors, that they might look different in different groups and that they might actually be more important. So for some therapeutic alliance, for example, might become a lot more important in this overall model. And again, that might change recommendations and what we might focus on and what we might try to intervene on. So it is very important to look at that. We also did have a limited number of depressed youth in this sample, which might have somewhat limited our ability to find this MFQ cut point. So it is possible that we can find a good one. And in future studies, we definitely would want to try to do just that. But overall, again, this study basically showed us that there are opportunities for intervention augmentation, and we can do those early. So for example, for child engagement, again, it kind of starts happening right from the beginning, or as treatment progresses later on, which is hopefully would allow us then to boost some of those response rates. And we can also see that there's two approaches, at least, to implement this clinically. So we are able to identify individual cut points, which would make this very accessible to individual clinicians. But we can also look at these algorithms, these bigger models, composite scores, potentially implement some machine learning as well, that may be feasible in larger health networks. And again, with that, if we're boosting those response rates, we would basically be maximizing the chance for treatment success. So yeah, thank you very much. And I would like to thank, of course, all of you for being here today, and also everybody that was involved in the project, from my mentor and the research team to all participating families.
Great, thank you so much, Pauline. It looks like Dr. Murray Stein has a question or comment, if you'd like to read that. If not, I'm happy to out loud.
Why don't you go ahead? Thanks.
Oh, okay. So he is commenting that the prediction of outcomes can often be accomplished in a particular study. And the question is, to what extent do you expect your results to be generalizable to other studies that might not use exactly the same measures, or to clinical practice?
Excellent question. I think that's one of the issues with all of this research, is that so far, a lot of the research that we're seeing, because different measures are being used, because different even definitions of what child engagement even means. So for example, does it mean that a youth just shows up? Does it mean that they're actually actively engaging? So there are a lot of discrepancies in the field still that make it difficult to generalize, and then to be able to do that. So I 100% agree. I think there's a lot more work to be done. One of the things that we did a little bit differently is that we tried to focus on the measures that are really actually being used for the clinical trial outcome. So focusing on the CGI, for example, rather than focusing on the self-reports for outcomes. And we're hopeful that with that, the likelihood of generalization is going to be increased a little bit. But of course, there's a lot more work to be done.
Great, thank you. Any other questions or comments?
Thank you so much.
All right. Well, if there's nothing else at the moment, we can move on to our next talk. So I'd like to introduce Dr. Samantha Chalker. She is currently finishing her postdoctoral fellowship in the VA and UCSD Clinical Research Postdoctoral Residency Program. She is trained as a clinical psychologist with a background in developing and evaluating suicide prevention interventions. She was recently awarded a Career Development Award funded by R&D to expand her work of integrating the recovery model and strength-based approaches to intervene on suicide risk for veterans with serious mental illness. Her CDA is centered on further developing and piloting a tool delivered by VA peer specialists to enhance safety planning for veterans with serious mental illness. So I welcome Dr. Samantha Chalker. Please take it away from here.
Thanks so much, Monica. I appreciate that intro and being able to be joining you all here today. This is one of the sub-projects that my team has been working on to support my CDA, looking at crisis service utilization following the completion of a suicide safety plan for veterans with and without serious mental illness. So just a little background, suicide prevention is a top priority issue for the VA, and veteran suicide rates continued to increase until 2017. And encouragingly, the 2021 National Veteran Suicide Prevention Annual Report described decreases in suicides among veterans in 2018 and 2019. Even though the general US adult population saw increases in suicide during that same time period. Nevertheless, though, veteran suicides remain higher than the general US adult population still. What we know too is that direct suicide-focused interventions are the most effective in treating suicidal thoughts and behaviors. And when I say a direct suicide-focused intervention, I mean really focusing on the suicidal thoughts and behaviors specifically. So not a diagnosis of major depressive disorder or post-traumatic stress disorder. You can think about it like how we have a trauma-focused therapy that's really focused on the trauma. We really want to be focusing on those suicidal thoughts and behaviors. And our standard of care in suicide prevention is really focused on first identifying these people who might be at risk and assessing them. That's kind of a big thing, especially if you work in the VA, or depending on where you work on, it can look a little bit different. But then also the recommendation for safety planning, which I'm going to talk a lot more about throughout this presentation. And sometimes safety planning does include means reduction, which would be, or it could be a standalone intervention where we're really trying to reduce access to lethal means for these folks who are at risk for suicide. And then also a common standard of care is sending out these caring contacts, which are non-demanding letters of care or phone calls, text messages, really kind of provide that additional support. And when we think about these direct interventions, then really only safety planning and with that means reduction are focused on that. And so we wanted to understand a little bit more about safety planning. And so I want to kind of break this down a little bit more. There's a bunch of different versions of safety planning, but I want to focus on the safety planning intervention, which has the most research behind it. And it is the standard of care in VA, a recommended and mandated tool. So usually there are 6 steps, and there are 6 steps within VA safety plan, where first you're identifying these personalized warning signs. And this is the veteran and their clinician that they're working with. And so these can be personalized. What gets you into this crisis? And then kind of moving forward, that next step is, okay, so you're thinking about suicide. You may want to act on this. What can you do to take care of yourself in this moment? What internal coping strategies that you use? If that doesn't work, then you're moving on to step 3 and 4, which are asking for these social contexts to either help you distract from the crisis or asking for help, being able to talk with them. And then step 5, that's when we're bringing in these professional agencies, which include the Veterans Crisis Line. And typically this is where we're listing out like what hospital would you go to if these thoughts and feelings became so severe that you couldn't manage them. And usually calling the Veterans Crisis Line is something that we're listing as a recommendation to do before you would go to the emergency department, right? So kind of thinking about this as like a hierarchy process. But interestingly, and how wonderful safety planning can be, there are really few efficacy trials for such a widely disseminated approach. And what we do know, though, is that when the safety planning is performed with high fidelity to the model, and then usually when augmented with follow-up services, given this is a one-touch intervention, they have shown reductions in suicidal behavior and psychiatric hospitalization in that next year. So that might suggest that people are using those earlier steps 1 through 4 to really help manage their suicidal crises. And so our group really wanted to understand these various steps and how that might impact outcomes. And so for this specific project, we're really focusing on the differences between veterans with and without SMI. And so when I'm talking about SMI, I'm thinking about, there are a lot of different definitions depending on where you're coming from, but these are folks who are experiencing psychotic symptoms. So that could be diagnoses like schizophrenia or other psychotic disorders. bipolar disorder with psychotic features, or major depressive disorder with psychotic features. And what we know is that in general, and in veteran populations as well, that they have a much higher increased risk for suicide. Veterans have higher suicidal ideation and suicide rates compared to the US general population and other veteran populations. And they also have these unique risk factors, like being younger, more likely to have substance use, and also knowing that they have this illness, this insight could also be an indicator of a higher risk for suicide. They also have differences in their suicide phenomenologies. So for example, those with SMI have been found to use atypical methods to die by suicide, like stabbing themselves, versus more typical methods that we might see in a veteran population, like using a firearm. So the literature is really suggesting that these individuals with SMI are unique, and so that interventions tailored to these unique qualities of SMI might be more effective, given that but we really don't know if there's any that the standards of care in suicide prevention, including safety plan, is sufficient for those with SMI. So that kind of brings me to this current project where we pulled a sample of VA safety plans, VA San Diego safety plans from this time window of beginning of a fiscal year all the way through the date that we pulled them. And so we wanted to have a year of a follow-up to look at these clinical outcomes. And so that left us with just over 1,600 unique veterans. We broke them into this category of SMI versus no SMI listed in their chart, and then wanted to look at these different binary outcomes for that following year after they completed their safety plan. So these outcomes that we'll look at are suicide attempts or deaths, which were all of these actually outcomes are from the veterans' medical records. So what was documented in there. And so for suicide attempts and deaths, that's documented by a suicide behavior and overdose report. And we combined attempts and deaths together just because of the low base rate of deaths. There were 5 in this sample, but it is an important variable to kind of keep in mind. And then inpatient psychiatric hospitalizations, emergency department visits. At the VA, we have a psychiatric emergency clinic specifically for psych-related emergencies. And then also this concept of that veterans crisis line that's listed on a safety plan. And so really our goal here was to examine this next year suicide attempt and death and these crisis service utilizations among veterans with and without SMI who completed this safety plan. We also have the second exploratory aim to really look at differences of the use of the veterans crisis line, specifically really to determine the differences of veterans with and without SMI who attempted and died by suicide in the next year, and whether or not they contacted the veterans crisis line as well in that same year. So a little bit of the breakdown of our sample, I'll just note kind of right off the bat that there are some limitations in the demographics here, given the limited and minimal descriptors that we had available to us, given that this was essentially chart review. Notably that we had a binary gender category, and the racial ethnic breakdown got a little blurred in what we were able to tease apart. But overall, the sample were mostly male and close to half identified as white, and almost 20% identified as Hispanic or Latinx. And they are age ranged from 19 to 97 years old, so quite a range there. And then in terms of diagnoses, these were coded into a hierarchy that were adapted from the VA mental health performance measures. And so if a serious mental illness was listed in their problem list in their chart, and let's say they also had a substance use disorder, we were coding that they did have a serious mental illness, putting them into that category. And so while over half of the veterans in the sample did have more than one psychiatric disorder listed, 12% had no psychiatric disorder listed in their chart. And so when we look at the breakdown for SMI, that was about a 10.5% in the current sample, which is pretty high given the larger rates of SMI. And so to dig into the findings a little bit here, there's a lot of numbers here, but I just really want to draw your attention to that these are the associations between whether or not somebody has an SMI diagnosis and that 1 year follow-up after safety planning. And so our significant findings here is that these hospital crisis services, those with SMI, were much more likely to use these services following safety planning. The suicide attempt and death finding was trending, but probably given the low base rate behaviors here. And then the unique finding here is that there were no differences between these SMI or no SMI in terms of calling that veterans crisis line in that next year. So in that exploratory aim, we then looked at the rate of suicide attempts or death in veterans with and without SMI, and then their use of the veterans crisis line following safety planning. And so in this figure, you can see the first graph is SMI, and they called the veterans crisis line. SMI, they didn't call the veterans crisis line. They didn't have SMI, they did call the crisis line, and that they didn't have SMI, and that they did not also call the crisis line. And so what we can see is that of veterans with SMI, 32% called the crisis line and attempted and died by suicide, while almost about 5% didn't call that crisis line, but still attempted suicide. So pretty, and that was a significant difference between those who did and did not call the crisis line. And then when we look over at the veterans without SMI, a little over 18% did call the crisis line, while 4% didn't call the crisis line. And so you can kind of see that pretty stark differences between whether or not you had those that veterans crisis line call. But between the two different groups, we actually didn't see a significant difference, but we can see that actually if you are a veteran with SMI and you called the crisis line, you were 1.8 times more likely to attempt or die by suicide in that same year compared to those veterans without someone who called the crisis line. So though that wasn't a significant difference. And so overall, the big takeaways from this study is that these veterans with SMI were much more likely than veterans without SMI to utilize those hospital crisis services in that following year, which is consistent overall with previous research about how frequently these crisis services are being used by those with SMI. But that there isn't a difference between veterans with and without SMI in terms of calling that veterans crisis line. And yet almost 1 in 3 veterans with SMI who did call the crisis line attempted or died by suicide. So this study actually just opened up a wide range of questions that we still want to answer in kind of our next steps. But really that it's showing us that we need to understand a little bit more about how this veteran crisis line is working compared to using those crisis hospital services, particularly around safety planning. It could be a really critical line for future research, and potentially that we can enhance the early steps in safety plan. So those things before you go to the hospital or call professionals, that might be in that kind of instead of option, and really enhancing that kind of first step or first couple steps. There are, of course, some limitations to this study, such that these are data from only one VA site. Our outcomes were derived from the VA clinical record, which is notorious for having an underestimation of suicidal behavior. So it's possible that those rates could be a lot higher. I think a pretty large limitation here that we want to conduct some future research on is just given the limitations of our data, we don't know if those hospital crisis services were due to increased suicide risk or some other component, and then just acknowledging that limited scope for those demographic descriptors as well. Really briefly, I just talked a little bit about some of those future directions. We are also really interested in looking at these outcomes temporally. So across time, did that veterans crisis line call happen before they attempted or died by suicide? And then when someone has more than one safety plan, given that this is something that should be updated, how does that impact outcomes? And as Monica mentioned in my introduction, I was recently recommended to be funded for a career development award, which I'm very excited about. And so this 5-year grant is really going to helped me create the structure to develop and evaluate a feasibility acceptability of a suicide-focused interventions delivered by VA peer specialists to really enhance safety plannings that are and really involve the tailoring this intervention to the cognitive challenges that these veterans with SMI might experience. And so one of the key practices in this intervention is that the peers will be working directly with these veterans to practice calling the Veterans Crisis Line, to practice asking for help. And so we're hopeful that that may have some impact, and looking forward to hopefully maybe presenting some of that next year. But at that, I'll just open it up for any questions or comments at this time. Thank you so much.
Thank you so much, Samantha. That was a great talk. We have a couple minutes for questions, so please feel free to speak up or write them on the chat.
Samantha, I'll jump in. Thank you for a really superb talk. This is such important work, and I know you have a big plan ahead of you with your CDA in 5 years. I was just wondering, one of the limitations you noted was that it's only one site. Have you connected at all with like the National Psychosis Registry within the VA? And is this the kind of thing you'd like to look at on like a broader scale to address some of these, acknowledged limitations that you have so far?
Yeah, that's a great question. I haven't connected with them, so maybe that's something that you and I could touch base about offline. But we have been connecting with Mark Ilgen, who potentially has a grant to be able to look more nationally across VA, so they would be able to pull those larger data sets. I think that San Diego is particularly fabulous at their suicide prevention interventions. And I could kind of go on about that. So it would be really interesting to look at areas where they're not so attuned to veterans with SMI and that particular cohort. So I do think there's a lot of opportunity to look more broadly there.
I would really like to help you with that. So I would thank you for the invitation to talk offline. We're in the National Psychosis Registry now and digging in and meeting with the leads for that for some other kind of data analytic projects. But such good work. Thanks so much for taking it on.
Thank you. Other questions or? Looks like Brian wants to invite you, Greg, to our, we do have a suicide prevention special interest group. So if any of you are interested in attending that at any point, it's a lot of what we're talking about there.
I'd be happy to.
Yeah.
I guess one question, if I could, great talk, obviously, but would be, why aren't they calling the crisis line if they're not doing that?
Yeah, so I think we were being cautious about not interpreting a non-significant finding that there weren't these differences, but we're wondering that potentially if there's any differences among if they're remembering to call the crisis line or if they have motivation to call, that some of the early work coming out of Veterans Crisis Line data is just, are people actually using this, and how effective then is calling the crisis line? So I think that leads to that kind of temporal question, or are they calling the crisis line and then attempting suicide, or has that attempt happened before? I think that's kind of the nuances that we want to be able to explore more, but it's potentially some of those cognitive challenges of veterans with SMI that might be hindering that use. But yeah.
Great. It looks like Mark Bondi has a comment to everybody that he's agreeing with Amy and Bill. Fantastic presentations across the board. Great forum to showcase the wide-reaching and cutting-edge work happening in the department. So thank you so much, Mark Bondi. If there's no further questions, we'll move on to our next speaker. And that's going to be our final speaker of the symposium. So I would like to introduce Dr. Corey Weissman, MD. He is a board-certified psychiatrist whose focus is providing care for patients with treatment-resistant mental illness. He serves as an assistant professor and medical director of interventional psychiatry at UCSD within the Interventional Psychiatry Clinic. His current research focus is on the development of novel treatments for suicidality in patients with severe mental illness. He has published on the use of transcranial magnetic stimulation as well as magnetic seizure therapy for patients with treatment-resistant major depressive disorder and comorbid suicidality. Dr. Weissman is also excited about the promise of psychedelic compounds and other interventional pharmacologic agents such as psychiatric treatments. He continues to develop his clinical skills in a variety of interventional treatments, while also now completing a PhD in pharmacology and toxicology. So without further ado, please welcome our keynote speaker, Dr. Corey Weissman.
Okay, thank you very much for that introduction, Monica. Never thought I'd give my first keynote address from my bedroom, but here we go. So today I'm going to be talking about a paper that our group recently published looking at the psychedelic effects on suicidality, specifically a meta-analysis. This is something that came out just a couple of months ago. A couple of disclosures. I do work as a consultant for a specific company, and I recently got a NARSAT award. So just to start off with, I want to talk about the outline of my talk today. So I'll talk a little bit about psychedelics, what they are, and what psychedelic therapy is. I'll talk then about suicidality and current interventions for suicidality that exist. And then I'll focus on the meat of the talk, specifically psychedelic therapy and its relationship to suicidality, and looking specifically at the meta-analysis that I'm going to be presenting today. And I'll wrap up by talking about limitations and future directions. So to start off with, what are psychedelics? So there's a number of different ways that we can define psychedelics. Chemically, psychedelics can be divided up into tryptamines, ergolines, and phenethylamines. And the commonly known psychedelics can be divided into those groups. So for instance, psilocybin and DMT are tryptamines, LSD is an ergoline, and mescaline is a phenethylamine. The common thing that these compounds share is structural homology with serotonin, which you can see on the bottom there. And that's important because it's thought that the common mechanism of action of psychedelics in people is through a specific serotonin receptor, the 5-HT2A receptor. Being that the psychedelics are either agonists or partial agonists at this specific receptor, which is found pretty much throughout the brain, although it's found most densely in specific areas. And there's been some interesting recent research looking at how psychedelics affect the brain on a whole brain level, and how it affects certain circuits, such as the default mode network. And I'll only go into this briefly because of the length of time I have today, but essentially in psychedelic states, we see acute changes in mental state, which correlate with whole brain changes in network activity. And if you look at the right over there, you can see there's global increases in connectivity, which is associated with increases in entropy, or a measure of randomness of connections between different brain regions. And there's also some interesting work, some of it being done here at UCSD, looking specifically at how these brain changes are correlated with changes in immune function and also with neuroplasticity. So that's a brief primer on psychedelics. What's psychedelic therapy though? So psychedelic therapy is essentially combining the administration of a psychedelic for a patient in the context of a specific therapeutic paradigm. So in modern psychedelic research, that usually involves two therapists, a male and a female, sitting with the patient, which you can see at the bottom there, either with music playing or with eye shades on throughout the duration of a session, which is usually about 6 hours. This also includes baseline therapy sessions, sort of preparatory sessions, as well as integration sessions. So when we think about psychedelic therapy, it's not just giving a psychedelic to a patient, it involves baseline interactions with therapists, as well as integration work after the psychedelic session itself. So I'm going to talk a little bit now about the current treatments for suicidality that we have in psychiatry, and then I'll come back and speak specifically about how psychedelics fit within this paradigm. So we can divide up the main treatments for suicidality into three main groups. First group is common medications, and this includes antidepressants or SSRIs, which has mixed evidence for treatment for suicidal ideation and suicidality, with some evidence to suggest possibly increasing that risk in very particular groups. And then there's also lithium and clozapine, which have good evidence as anti-suicidal agents, but they're used mostly in specific clinical populations. There is evidence for specific psychotherapies, the second branch of treatments, which I'll discuss today for treating suicidal ideation. Two of them being cognitive behavioral therapy and dialectical behavioral therapy. Some of the issues with these treatments is that they take a long time to enact effects, and most of the evidence is in patients with milder forms of suicidality. So there are some limitations there. And then interventional treatment. So this is the area that I have specific medical expertise, and I'm doing some investigations into some of these specific treatments. There is very good evidence for ECT or electroconvulsive therapy for treating suicidal ideation in the context of depression. But there's limitations to that treatment in terms of accessibility and stigma. And then other interventional treatments, which are more experimental, include rTMS, magnetic seizure therapy, and ketamine, which are promising, but again, are experimental and have their own specific indications and limitations too. So when we think about psychedelics and suicide, some of us might think about the sensationalism that specific news media articles or broadcasts show of patients completing suicide or attempting suicide while intoxicated on psychedelics. And I helped form a small research group back in Toronto, which this paper that I'm going to present today is one of the fruits of that labor. And we wanted to look at what does the evidence actually show about the association between psychedelics and suicidality, and is there any evidence to show that it's actually beneficial for suicidality? And so there are a few studies that have been published looking at this question specifically. One of the leaders in the field, Carhart Harris, published on anti-suicidal effects of psilocybin in treatment-resistant depression. There's also been publications about the anti-suicidal effects of ayahuasca in recurrent major depression. And then specifically in cancer-related distress, which is a clinical population where there's been a number of studies with psychedelics. We've seen significant decreases in suicidal ideation. And then most recently, there was an interesting study looking at psilocybin head-to-head to escitalopram. And in that study, they did show significant decreases in suicidal ideation for psilocybin compared to escitalopram. So these are some interesting early studies, but they all have some limitations to them. Not all the trials, and I did mention trials in that last slide that do have suicidal ideation outcomes, but not all the psychedelics trials published to date have report on suicidality outcomes. A lot of the studies published so far are very small, and there's also limited research on, within the context of clinical trials, the acute and post-acute potential increases in suicidality in patients giving psychedelics. And then lastly, there's been no systematic review or meta-analysis on the topic, which is why our group decided to carry these projects out. So I thought it'd be helpful to talk briefly about the systematic review that our group published and as a sort of a primer to the meta-analysis. And in brief, what we found, so we did a large systematic review, and I'll go through the details of the actual search in a few minutes. But essentially, we found, going back to the 1960s, overall 64 studies, which included 3 randomized controlled trials and a number of other forms of research studies, including open label trials, longitudinal cohort studies, and the majority were actually case reports or case series. And we divided up the evidence into 4 different categories. So more recent or modern research, and then early research. And we also divided up the studies into those that we define as psychedelic therapy studies versus non-clinical classic psychedelic use, which is more recreational use or spiritual use in the context of traditional use or churches. And to sum all of the findings that we had from this study up, what we saw was that overall, if we can sum it up in a narrative fashion, psychedelic therapy is associated with decreases in suicidal ideation and suicidality. But classic psychedelic use outside of the context of psychedelic therapy has mixed evidence. And there is some evidence to suggest that it has increased association with suicidality in certain populations and contexts. So we followed up this systematic review with the meta-analysis, and I'm just going to go through sort of from the beginning to the end what we did and what we found in this study as sort of the meat of this talk today. So we essentially use the same search as this last systematic review, and we decided to include within that search only studies that involve psychedelic therapy clinical trials with those using substances with classic psychedelics. So the psychedelics with the known 5-HT2A activity, which included those listed here. We also only included studies that had a specific suicidal ideation measure that was something that we could quantitate in the meta-analysis. So we conducted this search back in 2020, repeated it in late 2020, and this was a study that was pre-registered on Prospero, which is an online repository for systematic reviews and meta-analysis. And because, as I mentioned before, not all the study data was published, we had to request data from all the study investigators of the overall 8 studies that we found that we decided to include. And we were able to get 7 out of the 8 studies data. So here's the Prisma diagram showing the search and how we ended up, started with about 10,000 papers and ended up with 7 at the end. And so what did we decide to analyze? So what we did in this study is we looked at changes in suicidal ideation from baseline to endpoint and calculated standardized mean differences over time. We only included patients that were given an active psychedelic treatment in that primary analysis. We also looked at study heterogeneity, and we looked at, which has been sort of a deficit in prior literature, elevations in suicidal ideation in all of the patients included in these studies, both acute and post-acute. And then lastly, we analyzed publication bias in our study as well. So I'm not going to go through the entire details of each individual study that was included, but a few things to highlight here. Of the 7 studies, the majority were open label trials. And for some of the studies, a significant portion of the patients did not have suicidal ideation at baseline. So we had to exclude a lot of patients from our primary analysis. The majority of the studies involved psilocybin as the active treatment. But as you can see here, there were a couple of studies that also looked at ayahuasca. So we only really included ayahuasca and psilocybin as the active treatments. And then there was also some heterogeneity with regards to the suicidal ideation scales that we included, which you can see in this column over here. So there was the QID scale, there was the BDI scale, and the Columbia scale, as well as the MADRS suicide item scale. And I just wanted to show you the raw data here, not for you to pour over each individual number, but to point out a couple of things. Firstly, that the baseline suicidal ideation was relatively low compared to the actual entirety of the spectrum of suicidal ideation you can get on these scales. And also the data itself was a little bit patchy with regards to the time points that we could include. Because all of these studies obviously were not done in coordination, the time points that were assessed by all the authors were quite heterogeneous. But what you can see is that overall, we see decreases in suicidal ideation across the majority of the studies and the majority of time points. And so this is sort of the main summary slide, which I think is the take-home slide from my talk, and goes through the most important findings. And what it is essentially is a kinetic meta-analysis, so showing changes in suicidal ideation as measured by standardized mean difference over the different time points from baseline up until 6 months. And so the main things are that we see significant effects up to 6 months of reductions in suicidal ideation. But the strongest effects with the most solid data seem to come at the 1 day up to 4 to 5 week mark, where we're seeing very consistent, strong reductions in suicidal ideation with narrow confidence intervals. And the 7 to 8 week mark, we're not seeing any significant effects there. So that's sort of the main take home in terms of reductions in suicidality. As I mentioned before, we looked at increases in suicidality, and overall, we did not find many increases, especially given the nature of the clinical populations in the studies. We found for acute suicidality, so within 24 hours, there were 2 patients who had mild elevation, which subsequently reduced and went back to 0. And in post-acute suicidality, so after 24 hours, we see 5 patients with mild elevation, in which 4 of the 5 had reduction back to 0, and 1 patient had consistently elevated mild suicidal ideation. Another thing to note, in looking at the source studies, two of the studies actually in their supplementary material essentially demonstrated that in their studies there was an adverse event that was related to suicidality, although not deemed to be or thought to be connected to psychedelic administration. So in the Griffiths paper in 2016, there was actually a patient who completed suicide, but this was about 2 weeks after the treatment session, and it was after the patient was given placebo. In the session, that patient apparently said that he was feeling bored and actually dropped out of the study. And so the study authors didn't think this was related to psychedelic administration itself. And in the next study, Anderson et al., there was a patient who was given active psychedelic treatment and 2 months later had a sublethal suicide attempt. But this was in the context of stimulant abuse and a psychosis that that patient later developed. And so I don't think that these 2 specific events point to psychedelics as potentially causing suicidal attempts or suicide completions, but it does emphasize that within the context of psychedelic therapy trials, it's very important to closely monitor all these vulnerable patients. Okay, so now rounding out the data that we had in our study, this shows the heterogeneity and the publication bias metrics. So we can see, as I kind of alluded to before, the levels of heterogeneity were smallest at the time points that we had the largest number of patients included in the sample, about 1 day to 5 weeks. And around those specific time points, we also had the largest fail-safe N, meaning that we were fairly confident specifically in those time periods of low publication bias. And we did also complete funnel plots to also measure publication bias. And this is difficult to do with a study with so few source studies included. But overall, we did find relative symmetry in these funnel plots at all time points, which also denotes low publication bias. Okay, so limitations and future directions. So, you know, this is we produced the first meta-analysis on the topic, which pushes the field forward, but overall we had very few randomized controlled trials and data to include in the study. So in the future, we're hoping to see more randomized controlled trials with larger samples, and also to recruit studies that recruit samples with higher suicide risk at baseline. In addition to this, we'd like to do some analyses that look specifically at moderator effects and mechanisms of action of how psychedelics might be working in these distinct patient populations. So in summary, in our meta-analysis, we found that modern psychedelic therapies associated with large, rapid, and sustained reductions in suicidal ideation, acute and post-acute elevations in suicidal ideation are overall rare and limited. And psychedelic therapy may show promise as a rapid-acting intervention that targets suicidality and may fit somewhere in our interventional psychiatry model in the future. Although a lot of additional research is needed to look at this with scrutiny and in fine detail. And that's it. I just want to acknowledge my supervisor and the chair, Dr. Daskalakis, as well as the whole interventional psychiatry team, and also my co-authors and collaborators from all over really North America who were instrumental in this study. Thank you very much.
Great job. Thank you so much, Dr. Weissman. Please feel free to ask any questions that you have.
I had a question. I noticed that, or maybe I missed it, that you were much more focused on suicidal ideation, and given how close the time windows were, was there any data that we're suggesting around suicidal behavior yet, or is that outcome just too far in the future for these studies to be reporting on yet?
Yeah, that's a great question, Samantha. The short answer is yes. The best high quality data that we could get at this point is suicidal ideation. And as I mentioned, the level of suicidal ideation is fairly low overall. So you can imagine that suicidal behaviors themselves are also quite rare. If you look at the systematic review that we published, there's a little bit more detail on specific suicidal behaviors, but it's all qualitative data. It's not quantitative at this point. Yeah.
Thanks so much, and thanks for the talk.
Thank you. Yeah, I thought your talk was amazing and kind of dovetailed into my talk so well. So it was really nice to see.
Yeah, thanks so much.
Corey, thanks for a superb talk. That was really wonderful work. You mentioned some of the concerns in previous studies about suicide attempts, suicide completions in all arms of the trial. And I just wanted to come back around to that point that you made. Suicide, I think, is one of the things that is a necessary, not necessary. It's an unfortunate part of working with patients with severe depression. And so I wonder, in some of these studies for psilocybin and other psychedelic assisted therapies, how those rates match up to treatment as usual, treatment with other forms of therapies. Is it better or worse? The data looked pretty encouraging, what you showed. Do you have any info about that?
Yeah, that's a great question, Greg. And I think the short answer is we need larger, better studies to enable to compare these things directly. I didn't go through it in detail, but a significant proportion of the patients included in these studies, their primary diagnosis was end of life anxiety and depression. So it doesn't really match up to a traditional treatment-resistant depression group. But a couple of the studies do have treatment-resistant depression as the primary diagnosis. So I would say that the results from this study are likely a little inflated compared to traditional treatment-resistant depression studies in terms of the effects that we see with treatments like ketamine or ECT, but they still are very encouraging. And it is fair, it's pretty amazing to see significant decreases weeks to months outside of a treatment in which you're essentially giving most of these patients just one treatment session.
Yeah, the effect sizes are terrific.
Mm-hmm.
Really impressive.
Any other questions?
Well, I'll just read off and like to thank you, Corey, as our keynote. This means that you're going to have to help us organize next year's session. So thank you for agreeing.
No one told me that when I signed up to give the keynote.
Yeah, thank you for agreeing in advance to do that. And I really want to thank Monica Fedoroff for doing an outstanding job as our MC for this year and organizer. And just once again, thank the presenters and their mentors for really creating a terrific environment and many superb talks. One of the comments that I read as we were going through the day kind of echoes, my own impression is that the work presented today rivals what we see in top scientific presentations. And so really appreciate the presenters, the mentors, and the team members that went into pulling this together. So, Monica, do you have any last words?
Yeah, thank you so much, Greg. And again, I want to also thank all of the presenters for showcasing their hard work and very exciting projects. We had a good variety of topics today, from starting with, addiction to cognitive impairment and Alzheimer's disease, as well as anxiety, depression, suicidality, and then the future promise of interventional psychiatry treatment modalities with Dr. Weissman's closing talk. And as I just want to reiterate, as mentioned in the beginning, we received so many outstanding abstracts. So I do want to recognize everyone who submitted their abstract for just the caliber of their work and ongoing contribution to the scientific community. Again, though, there will be more details to follow, but the poster virtual session will be May 17th from 9 to 10:30 a.m. And then I personally would also like to thank the highly skilled individuals who helped seamlessly organize this event, including Dr. Greg Light, Dr. Jeff Daskalakis, Jennifer Hickey Hinojosa, and everyone else who was able to make this possible. We're just really grateful to have the opportunity to continue this department tradition and encourage, further support, promote, inspire students, residents, and faculty at UCSD. And then personally, I just want to thank you all for your attention. It's been an honor to serve as the moderator today, and I really appreciate you all taking the time to listen to your very impressive colleagues. So thank you so much. All right. Well, if there's any additional comments, now would be the time, and then just feel free to reach out to any of the respective speakers if you have some questions that arise later in the day or week or whatnot. So thank you so much, everyone.